Hello, everybody. Thank you for joining today's webinar. This is Thrombosis Canada initiative, and we will be presenting on highlights from the American Society of Hematology 2021 conference with a bit of a spin from a Canadian perspective. So it's a pleasure to be here with all of you and with my co-speakers this evening. We had done the ISTH update as well, so it's great to be working with everyone again. While we're waiting for some more people to join, I'm going to go through our objectives for this evening. And what we really want to highlight is for Canadian healthcare professionals to look at the ASH 2021 Congress hematology-related presentations and how they're important to our practice. We'll deliver an opportunity for discussion on the latest developments in hematology and offer an opportunity for healthcare professionals to engage with our panelists this evening from across the country. So for our faculty this evening, I am Lana Castellucci, and I'm a thrombosis physician and researcher at the University of Ottawa and the Ottawa Hospital Research Institute. And I have my colleagues with me, Dr. Gregoire, who is also a thrombosis specialist, and he is a member of the Division of Hematology at the University of Ottawa. He's the director of the thrombosis program and a senior scientist at the Ottawa Hospital Research Institute. And we also have Dr. Mark Belletrutti, who is a pediatric hematologist and medical director of the Pediatric Bleeding Disorders Program at BC Children's Hospital in Vancouver. And we have Dr. Alfonso Iorio, who is a professor and chair at the University of McMaster, where he is the Director of Health Information Research Unit and the Hamilton Niagara Hemophilia Program. So it's a pleasure to be working with all of my colleagues this evening. And each of us will present on a topic that is either COVID-related or non-COVID related. Myself and Mark will be speaking about COVID-related aspects from the ASH Congress this year. So these are my disclosures, and each presenter will have a similar slide for their own disclosures. And moving through to the program, we need to disclose our commercial support. So our program has received support from BMS Pfizer Alliance in the form of an unrestricted educational grant. And there are potential conflicts of interest, with the speakers being eligible for honorarium from Thrombosis Canada. The BMS Pfizer Alliance benefits from the sale of a product that may be discussed in the program. And we do have strategies to mitigate potential bias. The content of this program was developed by the faculty and peer-reviewed by Thrombosis Canada. Recommendations involving clinical medicine are based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the program in support or justification of patient care recommendations conforms to the generally accepted standards. So I will begin our session this evening, and I'm going to talk about some COVID-related abstracts that were presented. And the learning objectives for my portion are really to understand the relationship between DVT and COVID-19 vaccinations. And the second abstract that I will discuss is actually an update on the ASH COVID-19 and anticoagulation guidelines, with a specific focus on acutely ill patients and post-hospital discharge. So we'll begin with this abstract, and this is deep vein thrombosis after COVID-19 vaccination. And this is from a group led out of the Mayo Clinic in Minnesota. The abstract number is 291, and I've highlighted the link there so that you can access it if you're interested. Now, the purpose of this study is to evaluate the different COVID-19 vaccines in the United States, and those included Pfizer, Moderna, and Johnson & Johnson, or Janssen is the other name. And as we all know, vaccine-induced thrombotic thrombocytopenia has been reported following the Johnson & Johnson and Moderna vaccines. And what this group was wanting to assess is whether or not the DVT rates were coincidental with vaccination. And of course, this is excluding patients with VIT. And so the aim was really to evaluate trends in DVT diagnosis before and after COVID vaccination. And this included evaluating their electronic medical record at the Mayo Clinic Enterprise, and they reviewed between the dates that are listed there. And they looked at adults who'd had at least one dose of one of the COVID vaccines that were listed on the previous slide. The group also looked at upper and lower limb ultrasound reports that occurred 90 days before vaccination and 90 days after vaccination. And they were using the first dose for the mRNA vaccines. And of course, Johnson & Johnson is a single dose vaccine. And so they were reviewed for acute DVT diagnosis, and they used something called a natural language processing algorithm to identify the diagnosis of DVT on those ultrasound reports. And what they included overall from their EMR search was nearly 400,000 patients who had received at least one COVID vaccine. And the median age in this overall group of 380,000 patients was 61 years, and 55% were male. And I have here on the table the breakdown of the vaccines that were given. So the majority of people received the Pfizer vaccine. And in that group of people receiving Pfizer, the mean age was 56 years. 56% were women. And in terms of non-white race, this included 8% of people. And then the next most common vaccine administered was Moderna at 32%. Again, mean age was 61 years and 54% were women. And almost 8% were non-white race that received the Moderna vaccine. And then for Johnson & Johnson, much less common to receive this at 4%. Nearly 50% were women that received the vaccine, and they were 55 years for the mean age. And 21% were of non-white race. Now, importantly, the Mayo group includes different health sites, so not just in Minnesota, but also Wisconsin, Florida, and Arizona. And so those numbers are listed there for the breakdown of the states that these people were identified. And moving on to the results when they looked at this 380,000 patients, when they evaluated the ultrasound imaging using their algorithm, in total, they had nearly 7,300 upper and lower venous ultrasounds done in almost 6,000 patients. And what this figure is showing is, you can see on the bottom timeline here of day 0, which is the day that they received their first vaccine dose. And they looked at the 90 days before that and the 90 days after that. And you can see that there was certainly an increase in the number of vaccines performed after people had received their first dose of COVID vaccine. So ultrasounds were certainly more common after the fact. And that's what this box plot is highlighting. When they looked at their ultrasound reports, what they identified was 808 ultrasounds, including an acute DVT diagnosis, and that is in 714 patients. And so that worked out to 11% of their overall cohort. And they looked at both upper and lower extremities, as I mentioned previously. And 10% of people had diagnosis of DVT on lower extremity ultrasound, and nearly 14% on upper extremity ultrasound. Now, when we put all this together and look at the overall rate of acute DVT, so combining both upper and lower extremities, this was 1.86 per 1,000 patients. And this is very consistent with the expected background epidemiological rate. So nothing to suggest that there was an association of increased association between DVT and COVID vaccine. Some other information that the group presented was the probability of DVT on a daily basis in the 90 days before and after. So this is reported by ultrasound. And so you can see that, again, very similar both after vaccine compared to before, not a significant amount of difference there. And they also looked at pre and post vaccination DVT rates, and that's what this graph is showing. So in blue, we can see the pre-vaccination DVT rates, and in red, the post-vaccination DVT rates. And what you see statistically different. So it's nearly 11%. Pre-vaccine, it was 11.5%, and no statistically significant difference was shown between these two time frames. On this table, what I'm showing is the rate of DVT diagnosis according to each brand of COVID vaccine. And I've broken it down into the pre-vaccine time frame of 90 days as well as the post-90 day. And what you see here again is that for those who received the Pfizer vaccine, very similar rates of DVT pre and post-vaccination of nearly 11%. With Moderna, again, very similar pre and post-vaccine rates, 11 to 13%. But you will notice that there is a difference in the Johnson & Johnson, with 18% of people being diagnosed with DVT pre-vaccine compared to 7% post-vaccine. And that was statistically significant. And the authors suggest that for whatever reason in this smaller group of patients, that perhaps they were over-investigated pre-vaccine. We also wanted to look at what is the time to event rate of DVT diagnosis after COVID-19 vaccination. And this is shown according to each brand of COVID vaccine. So in red, there's Janssen or Johnson & Johnson, green is Moderna, and blue is Pfizer. And you can see that overall, they're very similar rates. And in particular, in the first 10 to 30 days, there is a fair bit of overlap that you can see there. On this table, what I am highlighting is what the hazard ratio is for DVT diagnosis post-vaccine. And what you can see for all of them is that all of the confidence intervals include 1, and they all overlap with each other. So there is no association of DVT with any of the COVID-19 brands. And they also did adjustment for sex and age with Moderna as the reference vaccine. And compared to Moderna, Pfizer, again, did not show a statistically significant increased rate of DVT diagnosis, and neither did Johnson & Johnson. So importantly, the summary from this abstract is that there was no increased rate of DVT following COVID vaccination as an overall group of vaccines, and there was no statistically significant difference in the risk of DVT post-vaccine comparing the different vaccines to each other. And so I think this is a really important thing because there's been a lot of concern, in particular post-VIT diagnosis after the adenoviral vaccines. And this has increased awareness of a lot of patients and perhaps increased their hesitancy to proceed with vaccination. So I think this is a reassuring piece of information that we can share with our patients and with colleagues about discussing with patients risk of DVT following COVID vaccination. And so that's the first abstract that I'm going to discuss. And I would encourage our participants to please add their questions to the chat box. We are going to answer all questions at the end of the presentation, so after the 4 speakers have concluded. So please continue to use the chat box to add your questions throughout the presentation. I'm now going to go on to the second abstract, if you will. And as I mentioned, this is an update on the ASH guidelines on anticoagulation in patients with COVID-19. And what this slide is highlighting is that it's an international panel of experts who are on this guidance. And really, this is a living document that is regularly updated depending on the information that becomes available based on clinical trials, et cetera. And I've got a link here on the right-hand side that you can use to find the most updated guidance. Now, there are some recent updates, and as I mentioned, we're going to talk about acutely ill patients as well as post-hospital discharge. So when we look at the acutely ill patients and specifically a recommendation called 2B, now acutely ill patients are those who are admitted to hospital and specifically admitted to a hospital ward. So these are non-critically ill patients. So another term for this group of patients would be moderately ill. And these are patients who are not requiring any significant advanced clinical supports. And the question that this panel is looking at is whether or not these patients should receive prophylactic dose anticoagulation, intermediate dose anticoagulation, or therapeutic dose anticoagulation. And so again, these are COVID-19 patients admitted to a hospital ward without requirement of advanced clinical support. And so this would be patients on low flow oxygen, so mild to moderate hypoxia. These are not patients who are on high flow nasal cannula. And so what did the panel recommend? So as of December 16th, this is when their update was posted. What the panel is now suggesting is that therapeutic intensity over prophylactic intensity anticoagulation for patients with COVID-19 related acute illness who do not have suspected or confirmed VTE or other indication for anticoagulation receive that therapeutic intensity of anticoagulation. And so this is different compared to their previous recommendation, which was posted in September 2021. And this is because more information from clinical trials has become available in that time period. What they're also recommending is that individual patients have a risk assessment of both thrombosis and bleeding to help inform the anticoagulation intensity that is used. And it may be preferred that a lower dose of anticoagulation be used for patients that are considered to be at high bleeding risk with low thrombotic risk. They also state that either unfractionated heparin or low molecular weight heparin be preferred over other anticoagulants because that is what the clinical trials have primarily focused on using, either unfractionated heparin or low molecular weight heparins. And so that is their recommendation. And this is another summary of that. So in the top box up here, you can see that the recommendation in September 2021 was suggesting prophylactic intensity anticoagulation over intermediate or therapeutic intensity. And now, as of December 2021, this update suggests using therapeutic intensity over prophylactic intensity. Now, this was open for comments during the month of December, and that closed at the start of January. So if there are any comments that people made, those will be taken into consideration before this is progressed towards their publication. And so that's the summary for acutely ill patients. And the next portion that we're going to focus on are patients who have already been discharged from hospital after being admitted for their COVID-19 illness. And this is an update with a conditional recommendation against outpatient anticoagulation prophylaxis in these patients who are recovering from COVID-19 infection. And this, of course, would not include patients that have suspected or confirmed VTE diagnosis or other reason to be on anticoagulation. So in February 2021, the ASH panel published guidelines to help clinicians determine when thromboprophylaxis in discharged patients should be considered. And they noted that thromboprophylaxis may be appropriate in some patients that are considered to be high risk for thrombotic complications and low bleeding risk, and that patients should be engaged in that individual decision-making. And they also indicate that there's data to support this new recommendation is very uncertain. And at the time that this update was published, they were waiting for results of an ongoing clinical trial. And so overall, what this update is recommending as of November 2021 is that the average patient discharged from hospital after their COVID-19 infection should not receive post-discharge anticoagulant thromboprophylaxis. Now, since this recommendation was made, some of you may have heard of the Michelle trial, which was published in The Lancet. And that is a post-discharge thromboprophylaxis study that was conducted in Brazil. And I apologize, I don't have slides on it, but I will briefly touch on it. And it was a study of approximately 320 patients that were randomized to receive rivaroxaban 10 milligrams daily or nothing, or no anticoagulant for 35 days post-discharge. And patients had to be identified as having higher risk of VTE in order to qualify to participate in the study. And they used something called the IMPROVE score to determine that risk, as well as D-dimer levels. And it was a composite outcome that included both symptomatic and asymptomatic VTE. So all patients had alternating scans of their chest to evaluate for DVT and PE. And they also included things like all-cause mortality and other arterial events. When they put the information all together, they found that those patients that received rivaroxaban 10 milligrams daily did have a benefit with respect to reduced primary outcome. However, when you look at the individual components of the composite outcome, none of them alone was statistically significant. And so I don't know how different guideline panels will interpret that information and how it will influence recommendations such as this. For the time being in my own practice, again, I'm not prescribing post-discharge prophylaxis to all patients leaving hospital after COVID-19 infection, but I am considering their individual risk. And if I do feel that their risk is increased, I may offer them prophylaxis. And something like rivaroxaban 10 milligrams daily is quite simple to use, and so it's a reasonable option to consider. And so I'm done with my portion of the presentation, and I'm going to pass this over to Mark for his continuation on the pediatric population.
All right, thank you. Good evening, everyone. As mentioned, I'm one of the pediatric hematologists here at BC Children's in Vancouver. What I'm going to talk about is more COVID. First of all, these are my disclosures, and none of these disclosures are any therapeutics from specific to these companies will be discussed in my slides. So I'm going to come at COVID-19 from the bleeding side, specifically patients with immune thrombocytopenia, and review with you two presentations related to vaccination in ITP patients, and hopefully help you arrive at a reasonable shared decision if you still have ITP patients who are hesitant about getting COVID vaccination. These two studies were adult-based, but I will have some comments from the pediatric perspective. And then I'm going to talk quickly about one poster in children with severe iron deficiency anemia, which is better, blood transfusion or iron. And so we'll get to that at the end. So COVID vaccination and ITP. These were two studies, numbers 586 and 587. They were oral presentations presented back to back in the same session, and one was from New York State, looking at vaccination in patients with pre-existing ITP, and then there was a similar study from the Netherlands looking at the same population. And the reason for this is we do know that there are occasions where vaccines can be associated with onset of ITP. MMR vaccine has classically been described, and this tends to be a mild, self-limited, recoverable ITP. And certainly this occurs at a much lower rate than ITP caused by any of the diseases that this vaccine prevents. There seems to be further inconclusive causality with inactive vaccines in general, and there's been scattered reports of ITP recurrence or exacerbation with the influenza vaccines. And prior to these presentations, there was one US center reporting their onset of ITP after the first COVID vaccination. And this was in a population where almost everybody received mRNA vaccines, and they had 6 out of 52 patients presenting with an ITP exacerbation. So what these two studies looked at, the New York study was a retrospective cohort. They looked at 10 hospitals in the Cornell University network, as well as they gathered data from 2 patient organizations, the Platelet Disorders Support Association, did an online survey around the time of their data collection, as well as a UK ITP Support Association online survey. The Dutch study took a different approach, and they actually had a prospective cohort of both ITP patients and healthy controls, and they collected platelet counts before vaccination and then 1 and 4 weeks after each vaccine dose. And then their definitions were both similar for an ITP exacerbation. Either they're both defined a stable platelet count as being within 20% of the pre-vaccine level, and then an exacerbation was either a 50% decrease from baseline or platelets dropping below 30, even if that was more than 20%. And then the Netherlands had one extra condition for exacerbation, which was if they needed rescue medication for their ITP of any type. So this is the first results from the New York study, and they had 117 patients. Most were around the age of 60. These were patients with long-standing chronic immune thrombocytopenia. 2/3 were women. The majority of them had been treated with, these were the top 3 treatment modalities, indicating quite a chronic group. And of the 117, there were about 40% who were actually off treatment, and 16 of those 48 had a normal platelet count. You can see here that almost 90% of them received an mRNA vaccine, with a smaller number receiving the other common vaccines. And so looking at what happened to their platelet count following vaccination, you can see here that about 1/3 with both the first and second dose either went up a little bit or went up a fair amount. Another 1/3 stayed stable. And then there was 1/3 who had a drop in their platelet count, with about half of those patients only dropping more than 20%, but less than 50%. And then another 15 to 20% having a decrease of more than 50% of their baseline. And you can see here that there was a number of drop-offs from first dose to second dose, probably owing to these results in some of the patients. If we looked at who were the patients more likely to have an exacerbation, again, there wasn't a difference between dose 1 and dose 2, dose 1 being in red and dose 2 being in orange. But when they looked at patients who had had a splenectomy at any time, there seemed to be a increased risk in both with first and second doses to having an exacerbation. And in those patients who were quite heavily treated for their ITP, again, there seemed to be an increased risk, more pronounced with the first dose compared to the second dose. And then they tried to analyze composite risk for this. And what they found was in those patients who had less than 5 therapies and no splenectomy, they tended to have a very low rate of exacerbation. That rate went up if you had splenectomy as one of your 4 or fewer prior therapies. And then you had increasing risk, albeit very small numbers, if you had 5 therapies, and then if you had 5 therapies that included splenectomy. However, they were able to rescue almost all their patients if they had an exacerbation that required ITP therapy. And they were able to use the medications that worked in the past for these patients if they needed to have their platelets raised. And what they also found was in 80% of the patients who had an exacerbation in dose 1 and needed treatment, they were still able to go on and receive a second dose without any major issues. In this cohort, there were no serious bleeding events reported. When they looked specifically at patients who were off treatment, of the 14 patients who received 1 dose, only 1 had an exacerbation, and same thing, only 1 after dose 2 had an exacerbation. Both of these patients had normal counts and were splenectomized patients as well. Patients with stable and increased counts after dose 1, there was about 14% who had an exacerbation after their second dose. What they did find was in this cohort that factors that were not predictive of exacerbation were age, gender, vaccine type, and the presence of another autoimmune disease. Looking at the other arm with the PDSA survey, again, what they found here was there seemed to be a signal that splenectomy seemed to lead to maybe more chance of an exacerbation or drop in your platelet count compared to those who were stable. And again, in this study, they had fairly comparable rates of mRNA vaccines and fairly similar number of female to male ratio and average age. And then in the UK study, a survey, again, 311 participants, but only 43 reported post-vaccination platelet counts. And in those 43, again, there was about a third who had a drop in their platelet count. And again, when looking at this survey data, they also found that splenectomy seemed to raise your chance of having an exacerbation following COVID vaccination. Now, keep in mind that these surveys could have had overlap with patients who were in the retrospective cohort as well. And so that has to be taken into account when looking at these three cohorts. Moving on to the Dutch study, again, they did a prospective approach and they enrolled 218 ITP patients. Again, the overwhelming majority received mRNA vaccination, and again, almost all of them received their second vaccine. And then there was a smaller number who received other vaccines. Looking at their patient characteristics compared to 200 healthy controls, really comparable in gender distribution and average age. And no surprise, the ITP patients had a lower median platelet count compared to healthy controls. And then the breakdown here, again, most of them were a primary ITP. Most of them were chronic. There was about a third who were in remission. 12% had splenectomy. A smaller number were needing rescue medication in the previous months. And there was about a third who were on a current therapy of some sort. But looking, comparing them to normal controls, while they did start with a lower median platelet count, the whole cohort, when analyzed, did not really have a major change in their platelet count as they went through the vaccine process. And really, there was no difference in the change in platelet count comparing healthy controls to those with ITP in this group. What they did find was about 14% of this group had an ITP exacerbation. 15 or 6%, 7% needed rescue medication. And those included either an intensification of treatment, additional IVIG, or starting ITP therapy. Of those who needed rescue medication, about half of them had a response and a complete response, and then 2 others had a partial response. Interestingly, they had 5 episodes of bleeding, but 4 of those patients actually had a platelet count over 100. And so we're not in an active ITP exacerbation. And the 1 patient who actually had a fatal esophageal variceal bleed had a normal platelet count. 4 of these 5 patients needed transfusion, but it seems that this bleeding was unrelated to an ITP exacerbation based on the platelet count at the time of bleeding. So, conclusions from both of these studies of over 300 patients. ITP exacerbations seem to occur in the minority of ITP patients receiving COVID vaccination. Those who did have an exacerbation responded to the usual rescue therapies that they had in the past. Heavy prior treatment and possibly splenectomy may increase the risk of exacerbation. And that was seen more in the US cohort than the Dutch cohort, but could potentially be related. And overall, both of these presenters concluded that COVID vaccination is safe and encouraged, but that risk of ITP exacerbation needs to be acknowledged. Probably close monitoring is recommended, especially in patients who have had heavy prior pre-treatment. Some unanswered questions that came to mind for me and really weren't addressed in these studies was, well, why does splenectomy increase risk? And is this just a heavy prior therapy effect, especially given that a lot of patients will try other therapies before proceeding to splenectomy? Or is there another immune mechanism that's at play here that needs to be teased out? Is the vaccine response affected if we need rescue therapy? Again, this was asked of both presenters, and really the answer isn't known. I mean, certainly, if one needs rituximab or IVIG, there's going to be a longer gap between vaccination, and neither of these cohorts measured any vaccine response in any way. So it's hard to know what the vaccine response is and potentially protection in patients who need ITP therapy to manage their exacerbation. Can we extrapolate this to children and adolescents? As a pediatric practitioner, I would say that a lot of our very difficult to control ITP adolescent patients look very similar to the adult cohorts that were presented in these two populations, and probably would have similar numbers, although there was no patients under 18 in either of these cohorts. I will say that for all my ITP patients, I have been recommending vaccination primarily because of these two cohorts in adult data, as well as the fact that acute COVID infection most likely will drop your platelets and exacerbate any ITP that is going on. So I think there is a role that you can have some extrapolation to the pediatric cohort, and I still recommend vaccine to my patients. I think we can be comforted that those patients whose ITP is recovered or they're off therapy or have normal counts seem to be less likely to have exacerbations, and I think that is reassuring for a lot of people and families. And the one other question that wasn't answered in these cohorts, which may be unique to certainly Canada, is are there effects of those patients who maybe have had a mixed vaccine picture, or have had one, say, AstraZeneca vaccine and then want to get an mRNA? Again, we don't have data on if those patients with ITP behave different, and that might be much more difficult to study given that ITP, there probably are fewer of those types of patients out there. So quickly, before we move on to our other presenters, I do want to give you one little pediatric nugget and a Canadian pediatric poster here. And this was looking at IV iron versus packed red blood cell transfusion for pediatric patients with iron deficiency anemia who presented in the emergency department. And this came out of the group at CHIO in Ottawa. And they were assessing this because of a recent American Society of Pediatric Hematology Oncology Choosing Wisely recommendation, which states that we shouldn't transfuse packed red blood cells for iron deficiency anemia in asymptomatic pediatric patients when there is no evidence of hemodynamic instability or active bleeding. And so they did a retrospective observational study looking at 55 patients who were seen in the CHIO emerge. And their primary objective was to see, one, how often did these patients get either IV iron or transfusion? And then their secondary objectives was, what was the hemoglobin recovery following IV iron? And what were the rates of transfusion or infusion reactions in this cohort? So of these 55 patients, you can see here, those who received iron sucrose was 11 of the 55. And again, most of them reflected the usual split we see in pediatrics. We see significant nutritional iron deficiency, especially in the toddler age group, and then significant menorrhagia in our adolescent age group. And there were comparable numbers. Those who were transfused, again, about half were nutritional, half were menorrhagia. There was one upper GI bleed. And then in the IV iron sucrose, again, 7 nutritional, 4 menorrhagia. And then in the full cohort, I didn't show the slide here. Again, it was a fairly even split between nutritional and menorrhagia being the main diagnoses for severe iron deficiency presenting to the emerge. When they looked at response to IV iron, it was comparable to transfusion, even for bleeding patients. So this panel on the left is bleeding, and you can see here in green is the hemoglobin response and number of days on the x-axis following IV iron compared to transfusion. And again, similar overlap in those patients who did not present with bleeding, but just iron deficiency anemia, and those with bleeding showed comparable results. As far as reactions, there were only 2 reported IV iron reactions, and they were fairly mild, a transient heart rate and temperature increase that resolved with slowing the infusion down, and 1 episode of GI upset that may or may not have been related to the IV iron itself. And then there were 4 transfusion reactions in the blood transfusion group, 2 fevers, 1 episode of nausea, and 1 more significant serious reaction of circulatory overload that required ICU admission. So there was a quick poster and some interesting early retrospective data that showed that IV iron resulted in a rapid rise in hemoglobin within 2 weeks without severe reactions or returns to the emergency department. Half of the transfused patients were infants with nutritional iron deficiency anemia, which one can question, was it necessary, given that a number of these patients can even be started on oral iron and recover their hemoglobin without the need for transfusion. Now, this comparison was limited because of the small sample and retrospective design, but it does raise a lot of future research questions and looking at this prospectively to see if IV iron can have a bigger role for severe iron deficiency anemia in the emergency compared to transfusion. So I'll leave it at that. And again, please put any questions that you have in the chat so we can discuss them later. And I will pass things on to our next presenter.
Thank you, Mark, and hi, everyone. So I'm Gregoire. I'm from Ottawa, from the thrombosis team, and I will present then 2 abstracts more focused on clinical non-COVID thrombosis. These are my disclosures, and I should add full disclosure as well that I ended not going physically to ASH this year and that I attended the virtual meeting. So this is a recollection of what I gathered from remotely watching the meeting, but also interacting with people and getting a sense of what was the most relevant things that were presented there. So 2 focuses. One of them was an updated systematic review and meta-analysis on trials using DOACs to manage patients with cancer-associated VTE. And there was also another interesting communication which I've taken part in on the risk of recurrent VTE among women who were using estrogen contraceptives at the time of their first venous thrombosis episode. So I will start with the updated meta-analysis on management of cancer-associated thrombosis. And as you know, so DOACs have emerged as an alternative to low molecular weight heparin for the management of these patients. And after the first, say, set of clinical trials a few years back, we did have more data coming in 2021. So the rationale was to update previous meta-analysis and provide even more precise estimates of the efficacy and safety of DOACs versus low molecular weight heparin in that population. So primary efficacy outcome was a rate of recurrent VTE, primary safety outcome major bleeding, and secondary outcomes were the clinically relevant non-major bleedings, as well as the all-cause mortality. So this is a summary of the studies that were included in that updated systematic reviews. And you can see on the right-hand side, the 2 newest additions to the team, so to speak, Castellucci and the other study here. And in terms of design, you see the intervention here. In the last one, any DOAC was possible. All used dalteparin and all had as a primary endpoint the risk of recurrent VTE. This is the main results on the primary efficacy, and I think it's quite interesting to see that everything was consistent across studies, and altogether you can see a rate of recurrent VTE of 8.3% on low molecular weight heparin versus 5.5 on the DOACs, and this was a statistically significant difference of minus 2.7%, risk ratio of 0.67. When you look at the safety and the primary safety outcome being major bleeding, again here, well, maybe more different at the beginning, early on in the first studies, less ever since, for a total global estimate of 3.7 versus 4.3, so 0.6% difference, not statistically significant. And for clinically relevant non-major bleeding, again, adding more studies provided more narrow estimates, And now the global estimate is 5.7 versus 9.5, so a difference of 3.8. And that did reach statistical significance with a relative risk of 1.66. So where are we at after that? So we start having, well, large number of patients to start with, so close to 3,700 patients. And overall, a significant reduction in the risk of recurrent VT when using DOACs versus long-term weight heparin, without a significant increase in the risk of major bleeding, but clearly an increase in the risk of clinically relevant non-major bleeding without impact on mortality, which I didn't show you. So the meta-analysis provide additional evidence for the use of DOAC as an effective first-line option in the treatment of cancer-associated thrombosis. And they say in patients who are not at high risk of bleeding, and as you know, that's where the details are in terms of patient selection. And while we certainly, that we've updated also the Canadian guidance document on who is actually a good candidate for DOACs based on these studies and based on the profile of patients included in these studies and the subgroup of who is more likely to draw benefit from being on them versus more likely to get harmed by their use. So that's it for that first one. And then the second focus is on a systematic review on the risk of recurrent VTE in women who had a first thromboembolic episode after a contraceptive related thrombotic event. So as you know, in the most recent classification of VTE risk factors, estrogen contraceptives are classified as a minor yet important risk factor. And the risk of recurrence after discontinuing anticoagulation in that subgroup remains unclear. We have had some contrasted results across studies, mainly due to small sample size in each of the cohorts that have looked into that. And overall, the risk seemed to be lower than in non-estrogen users, but this could have been confounded mainly by age and by other parameters as well. So the objective of this systematic review was to provide an updated estimate of the risk of recurrent VTE in women with estrogen-associated VTE compared with women with an unprovoked VTE. So the study looked at all cohorts, randomized trials, meta-analysis, and the criteria to be selected as a study was to have objectively confirmed estrogen-associated VTE, a minimum duration of 3 months of anticoagulation. Patient needed to have discontinued their estrogen contraceptive at the time of discontinuing anticoagulation in the cohort, and to be followed for the risk of recurrent VTE. And what was really good is that obviously in many cases these are just subgroups of existing cohorts, but the authors were able to reach out and to get additional data from the authors of the primary studies to get more data on these particular subgroups of interest. So altogether, there were 19 studies and a total of 1,500 women with more than 5,000 patient years of follow-up after an estrogen-associated VTE, and 1,900 women, close to 8,000 patient years of follow-up of women with an unprovoked VTE. And again, a great success at getting additional data from the primary studies. So the main result is that the annualized risk of recurrent VTE after stopping anticoagulation for a first estrogen-associated VTE was low. It was 1.22 per patient years. And you can see the 95% confidence interval here being between 0.94 and 1.59 with a very low heterogeneity. And as compared with all the women with unprovoked VTE, this risk was significantly lower with an incidence rate ratio of 0.34. But obviously that would compare to women of any age who would have had an unprovoked VTE. And when restricting to the subgroup of women aged less than 50, the incidence ratio was 0.51, and the 95% confidence interval was crossing 1 in that case. So no significantly less events than in women with unprovoked and an age below 50. So the conclusion was that overall, the risk of recurrent VTE appears to be low in women after a first episode of estrogen associated with VTE. The risk is lower than in women with unprovoked VTE, but this association may still be confounded by age, and only a minority of the included study provided age-adjusted analysis. But the fact remains that that's certainly a helpful number to help clinicians and patients in their shared decision-making on the duration of anticoagulation after such an episode. And I will stop there and let Alfonso for the last part of that.
Good evening, everyone. These are my disclosures, and this is the topic I'm going to discuss with you in the next 20 or so minutes. I'm another proud virtual attendee of ASH, but I've been deeply involved in this work and presentation, which anyways is based on for a good part on the original slide that Saskia presented at ASH. This is the panel composition. Saskia Middeldorp chaired the panel. I was the methodological chair. And then you see Kopiens, Lang, Moll, Krotzinger, Houghton, Andra James, Danielle Barrett, and Taya Meyer. Some of other members left the panel before the conclusion of the work. So the objective of my presentation are to provide background and methods overview for these guidelines, provide a case-based approach to illustrate the utility of these guidelines, and finally to provide a brief overview of the recommendation. So thrombophilia is a family of conditions associated with an increased risk of venous thromboembolism. What is still unclear and unsettled is whether thrombophilia testing helps with treatment and decision-making. There's controversy in this space, and this is what the panel focused on, essentially on the impact on thrombophilia on management strategies. So didn't consider testing alone, but testing and treating according to the test result. As to treatment, I want to point out that the panel did not review the evidence for treatment option, as those were taken from the ASH guidelines on treatment and prevention. Wherever we found direct evidence, we used that, but in most cases, we had to base our decision-making on modeling. And I want to spend a couple of minutes showing you what is the direct evidence was for our scope and how modeling was built. So direct evidence for the question about treating and testing would be a study where the population at risk of VTE or VTE recurrence was randomized to treatment as per current guidelines, so treat all patients or none of those randomized to that arm and counting the outcomes, or randomize them to undergo testing and treat only the positives. And of course, again, the assessment would be done based on outcomes. What is the corresponding modeling approach? Modeling would be, again, taking the population at risk of VTE or recurrence and assessing for that population the prevalence of thrombophilia, the risk of recurrence, the increase in the risk of recurrence associated with thrombophilia, and the effect of treatment. So the comparator group would still be treat all patients as per current guideline and counting outcomes, while instead the intervention group would be testing all and treating all the positive, and the number of positive would be a function of prevalence. On that number of positive with the expected number of events, assess the impact of treating the positive with a reduction of clotting events and an increase in bleeding events, and observing the negative untreated. So if you assume a situation with a prevalence of 40% of thrombophilia, which is close to the combined prevalence of all thrombophilia defect, and you assume a risk ratio of three times higher risk of clots in patients with thrombophilia, and an effect of treatment of 0.8, a reduction to 20% of the risk of event in the treated group, and a recurrence rate of 15%, a bleeding rate of 2%, what you would see in the comparator group would be then on 1,000 patients, you would have expected 150 events, 150 clots, reduced to 30 by applying anticoagulation, and you would observe 20 bleeding event per 1,000, major bleeding event per 1,000 patients. What in the intervention group? Well, about 600 patients for the prevalence of 40 would be negative, and they would have a VTE rate of about 8%. The 400 positive patient would have a VTE rate of about 21%, 3 times higher. We'll come back on how you split this risk. Now, the untreated would see the occurrence of 50 recurrences of VTE and no bleeding events. The 400 patients that instead were positive and treated would see a reduction of the 100 expected event to 20, 8 bleeding event caused. So the balance would be 50 plus 20, 70 events in this arm, and 0 plus 8, 8 events. And you would compare 70 and 8 with 30 and 20 to decide if treating or not. I told you how you split this risk. There will be a calculator associated to the guideline. This is the generic version that is available on the McMaster website. The one linked to this guideline will help with the terminology linked to thrombophilia. But as a matter of fact, what happened is that in assessing the risk in patients without and with risk factor, you have to split the overall risk in the population based on the association and the prevalence. It's not that if the risk is 15%, will be 7.5 and 15. It will be a combination of risk, 3 times the other, that multiplied the number of patients in each of the group will give the overall 15%. This can be done for risk ratio, odd ratio, and odds ratio. And this is what we did preparing the material for the guideline. So one last attempt at making this clear. In the treat-all group, all 1,000 patients, where you expect 150 clots, receive treatment. No one is tested, all are treated, and you observe 30 clots and 20 bleeds. In the test and treat, all 1,000 patients get tested. The 600 negative do not receive treatment. You expect and you observe 50 clots and no bleeding events. The 400 positive, you expect 100 clots. You treat them all, you reduce that incidence to 20, but you observe 8 bleed. So what is the result of testing and treated? 600 patients less receive treatment, 40 clots, 40 extra clots, and 12 less bleeds. Based on these numbers, the panel made a decision. For thrombophilia, the panel considered factor V Leiden, prothrombin mutation, antithrombin C, antithrombin protein C, protein S deficiency, and lupus anticoagulant. Any thrombophilia, when you'll find it in the guideline, means any one of any of these defects. Usually thrombophilia is tested as a panel, and so the moment you decide to test, you have to be ready to get any of the defects that may be there. What are population and outcomes? Population where patient with VTE and the outcome was recurrent VTE, patient without VTE but family members of individual with thrombophilia and or VTE, or the general population. In this case, the event of interest was first VTE, and of course, additional outcome for both groups was bleeding. 3 main strategies were considered depending on thrombophilia status. For patient with VTE, so secondary prevention was the intended intervention, the strategy was continue or discontinue, depending what the comparator was, anticoagulant treatment. So treat the positive or stop treatment in the negative. For patients without a history of VT, so primary prevention, of course, the intervention was prescribed anticoagulant prophylaxis. And for women, was avoid hormonal treatment, OCP of COC of hormonal replacement therapy, in addition to preventing clots. So let's move to see a few cases that are common to our practice and see what the recommendation would be. A 62-year-old male, otherwise healthy, with an unprovoked symptomatic DVT, femoropopliteal. The treatment guideline from ASH candidate this patient to indefinite duration of anticoagulation. Would thrombophilia be useful in this setting? Would the presence of thrombophilia change management? This is recommendation 1 of the guidelines, and the recommendation is a suggestion not to test for thrombophilia to guide the duration, but treat all as recommended by the other guidelines. Low quality evidence, but suggestion not to test to decide about treatment. This was based on evidence that was processed like I showed you before. So prevalence of thrombophilia approximately 38%, risk of recurrence assumed 10% for 1 year. The risk association with any thrombophilia, all thrombophilia considered together, 1.65, and then the relative effect of treatment, 0.15 for risk reduction for anticoagulation, 2.17 the increase in bleeding risk. And this would mean that by testing and stopping treatment in the negative, only treating the 380 positive patient, one would have seen 43 recurrences, 30 to 57. When instead treating all the 1,000 patients with anticoagulation, one would only have observed 11 clots. So essentially testing and treated would lead to 32 more VT recurrences in those 1,000 patients. 32 more events, 12 to 15. Of course, you would save some bleeding. If you go over the numbers, you would have 7 bleed in the 380 patient positive treated. When you would be treating all the 1,000, you would see 11 bleeds. And so the difference would be saving 4 bleeds by testing and treating only the positive. The panel decided that 32 extra event for saving 4 major bleed was not worth and suggested against testing for thrombophilia. Second case is a 58-year-old woman on post-op day 10 after abdominal surgery. Here, the ASH VTE treatment guidelines would recommend to treat for 3 to 6 months. Would there be any value in testing for thrombophilia after a surgery-provoked VTE? Again, the suggestion of the panel is not testing for thrombophilia and is based on a very low risk of clots and a very low risk of bleeding in this population, where testing 1,000 patients to only treat the positive would not produce any sizable benefit. So again, not to test for thrombophilia after surgically provoked VT. What about case 3? A 28-year-old, again human, with a PE associated with combined oral contraceptive. She has been on oral contraceptive for 10 years. The VTE treatment guideline would suggest to anticoagulate for 3 months and discontinuing the contraceptive before discontinuing anticoagulants. We should all continue the contraceptive to prevent pregnancies while the patient is treated for the clot and discontinue the 2 medications together. This is not usually our current practice, but this is what the ASH guideline correctly recommend. Would thrombophilia be useful in such a case? In this case, the ASH guideline, the panel suggested to test for thrombophilia and provide in that long-term anticoagulation to women positive for thrombophilia, as compared to stopping in everyone. Again, low certainty of the evidence. So it's a suggestion, it's not a recommendation, but this is somehow starting to change our practice. And the reasoning is that in those 1,000 women, where you expect to have 380 with some form of thrombophilia, any of the defect, you would observe 29 events by treating those patients. While if you were stopping treatment in all the 1,000 patients with all COC-related clot, you would observe 50 VT recurrences. So by testing and treating the 380 positive women, you would save 21 clotting events in those patients. And this was considered against the bleeding risk. So by treating those 380 positive, you would see 7 major bleed per year. You would see 5 major bleed in patient not on treatment for a difference of 2 major bleeds. So when the panel balanced saving 21 thrombotic events with provoking 2 more bleeds, decided in favor of suggesting testing and offering treatment to patient experiencing a combined oral contraceptive venous thromboembolism. Fourth case is a 35-year-old man. His sister is heterozygous for factor V Leiden and had a VTE. This patient is undergoing had a minor knee injury and now is undergoing immobility at home. What the recommendation from ASH is not to consider pharmacological prophylaxis. Would the case be different if this patient had thrombophilia? The recommendation 11 deals with this case, and it says specifically that in first and second degree relatives of patients with VTE and known factor V Leiden or prothrombin mutation, so our patient, you would not benefit from testing and treating the positive for any thrombophilia. The same guidelines, the same recommendation, says that, however, when the defect is antithrombin protein C on protein S, high-risk thrombophilia, then testing for any hereditary thrombophilia would be warranted with then treating the positive, or with offering the positive a prophylaxis around that immobilization. Again, this is at variance with current practice. We would not consider offering prophylaxis to a subject 35 years of age, bedridden for a sport trauma, a knee sport trauma. Looking at the evidence, looking at the balance of risk and benefits, the thrombophilia guidelines suggest instead that if the familial defect is antithrombin, protein C or protein S, it is worth testing for thrombophilia and offering prophylaxis to the positive subjects. My last case is 16-year-old. The older brother had a history of VTE and heterozygous prothrombin mutation. She considered starting combined oral contraceptive. Would she be benefiting from being tested for thrombophilia? Recommendation 19 says again that for families where the defect is factor V Leiden on prothrombin gene mutation, there is no indication to test for thrombophilia and treat the positive, or recommend against use of oral contraceptive in this case to the patient. But in first and second degrees of patient with known antithrombin, protein C or protein S deficiency in the family, instead the suggestion is for testing for the known familial thrombophilia and avoid oral contraceptive in women positive for thrombophilia over not testing and giving the offering treatment to all. Again, this was decided based on rate of recurrence and bleeds. And I can tell you that there was a strong support of the patient component of the panel for this guideline, this recommendation that goes against current practice, but protect patient in balancing their risk and benefit. So what are, in summary, the recommendation where there is suggestion for using thrombophilia testing as a guide to treatment? Patient with VTE provoked by non-surgical factors, including pregnancy or postpartum period, and combined oral contraceptive. In those cases, you would test and extend treatment to the positive. Patient with VTE at unusual sites where the local standard is treating patient for 3 to 6 months. Guidelines are not conclusive on what's the optimal duration for VTE when the VTE location is cerebral or splanchnic. So where the standard of care is treating indefinitely, there's no value in testing for thrombophilia. Everyone will receive treatment anyways. But where the standard of care is treating for only 3 to 6 months, then testing for thrombophilia and extending treatment in the positive would save events without too much eye of a price in terms of bleeds. Also, testing for thrombophilia in relative of patient with VTE and known high-risk thrombophilia, antithrombin CNS defects. Female relatives of patient with VTE and known high-risk thrombophilia when considering avoiding hormone use, and female relatives of patient with VTE and known high-risk thrombophilia to provide postpartum or antepartum prophylaxis, again, depending on type of thrombophilia, warranted for high-risk thrombophilia, antithrombin, protein C, and protein S. Finally, in ambulatory cancer patient without a personal history of VTE, first degree of patient with VTE and at low or intermediate risk of VTE. This is because for the patient at high risk of VTE, there's already a ASH guideline that recommend pharmacological prophylaxis to everyone. But for those at low or intermediate, when they don't have an history of VTE, but have a family relative, a first degree relative with a VTE history, thrombophilia testing seems to provide benefit when positive patients are offered thromboprophylaxis. Of course, there are plenty of limitations for these guidelines. The prevalence of thrombophilia may vary in different populations. That's why a calculator will be provided. Numbers and conclusion may be different in population where the rate of thrombophilia is different. Most of the recommendations were based on indirect evidence from modeling. There were very, very few studies comparing directly management strategies. And this analysis was done in isolation, from other risk stratification strategies. So we did not compare how, for example, testing for thrombophilia would compare with testing for D-dimer or residual clots or other ways of risk stratifying that, by the way, ASH did not support with the treatment guidelines. And this is my last slide. Thank you very much.
Thank you very much, everyone. That was really great presentations from all of our speakers. I would ask our participants this evening to please continue using the chat box to ask your questions. And while you're doing that, we do have a few questions already in the chat. And I also have some questions for my colleagues to get the discussion going. And, this has been a really interesting time with the ASH guidelines and some changes. And Alfonso, maybe I'll get things started with you while we're waiting for some people to ask some other questions in the chat. And you pointed out several times as you were going through your slides that a lot of the suggestions are different from our previous practice. And I wonder if you can comment about how assumptions were made and what that was based on, because it does seem to be very different than what we've traditionally done based on other guidances, and how those assumptions have impacted recommendations based on your modeling.
Well, what I think impacted the conclusion is not really the assumption, is the theoretical approach. In the past, thrombophilia was considered separately from the test and treat, and essentially without any comparator. Most of the reasoning behind the previous recommendation was how many thrombophilia you expect to have, how many clots they will have, what happens if they treat them or not. And there was a lot of emphasis on the cost of treatment. This panel took a different approach and looked at what happens if you do test for thrombophilia as compared if you don't test. And if you don't test and you treat everyone, there is a huge economic impact of treating all the 1,000 patients for life with anticoagulants. While if you test, yes, you spend some money up front, which is usually for a panel equal to 1 year of treatment, but then you save treatment in a good 60% of patients. So this kind of economical comparison was not done in the past. And also the reasoning of comparing not how many have or not thrombophilia, but what happens if I use then in a cascade the test result into how many events I would observe by treating or not based on test result. So the assumptions are based on the same exact literature. We did a review of the existing literature on thrombophilia prevalence, risk association, and so on. No news in terms of evidence. The logical framework was the one that Gregoire developed for a prognostic measure and for diagnostic strategies. That's, I think, the main difference. And that's why the conclusions were different.
Okay, thank you. And if I can maybe ask another question. So in all of your comparisons, it was, of course, risk of recurrent VTE balanced with risk of major bleeding. And yet some of the patients where some of these recommendations have been changed from previous practice guidelines, and I'm thinking about young women who've had either pregnancy-associated or COC-associated thrombosis. And we know that a lot of those women experience bleeding events that wouldn't necessarily be considered major bleeding events, but more in the category of clinically relevant non-major bleeding events. And those are bleeding events that often have very impactful changes on quality of life. And so how do we balance those recommendations now where there's a suggestion to continue anticoagulation long-term for women who have had COC-related VTE events?
Well, exactly the same way you balance the risk and benefit when this girl, instead of having a COC-related clot, has an unprovoked clot. So if you have an idiopathic clot in a 16-year-old, won't you candidate her to lifelong anticoagulation? She will have the same bleed that you'll see in the one that had the clot related to OCP. So we are really doing nothing different than we all do applying the ASH guideline on secondary prevention when the subject is young. The difference is that in this case, the clot is related to oral contraceptive, so you will see more in women than in men. But balancing the risk reduction and the risk of bleeding is no different from what you would do in idiopathic events, which is what we currently do.
Fair enough. I think women experience different bleeding events compared to men.
No, I understand, but
yeah.
the young girl with an idiopathic event is candidate to lifelong treatment. So it's not that a man with an idiopathic event gets lifelong treatment and a girl does not because she has more chance of bleeding. Or you can go into a conversation and decide that that girl wants to take the risk of recurrence to avoid risk of bleeding, but you would go against the ASH guideline that suggests to treat indefinitely. So it's only apparently different.
Right. We also have different ways to predict risk of recurrence in women compared to men, right? So there are different risk prediction models there that could be applied.
Yeah.
Yes, no. So thank you for that. I am going to move on to some other questions, if that's okay, because we do have some other questions in our chat box. Gregoire, I'm going to direct this question to your presentation, and it's from Leo, one of our pediatric hematologists at Sick Kids in Toronto. And he's wanting you to comment on timing of starting OCP in relation to when VTE diagnosis was made, if we know about that in the meta-analysis you presented.
Yeah, that's a good question for sure. And no, unfortunately, we didn't have the data. And a lot of things, as I told you, right, we're still intrigued by whether age is, like a confounding factor in that relationship. And that's typically another of the points that we need to clarify. So maybe next step will be to try, because we got such a good interaction with authors, to try to get an individual patient data meta-analysis so that we could get access to this type of extra information that would certainly be very useful in because, as you say, right, and sorry for everyone maybe not aware of that, there is a feeling that maybe, and some paper to suggesting that a bit, but not such much evidence to say that maybe if a clot occurs just within the few months after starting the birth control pill, then it's making it more provoked, and the risk of further recurrence might be lower as compared with someone who has been on the pill for 10 years and all of a sudden gets a blood clot. Is it really like estrogen associated, or is it more like an unprovoked clot? But the reality is that we have very little data on that. So you're right that we're hoping to get more insight on that from the studies.
Great, thank you. And Mark, because you are also a pediatric hematologist, what is your practice on this? And if you see any of these young women with COC-related clots, and what's your approach to that?
Yeah, certainly not much different than what was discussed, and that's it's a risk discussion for that young woman. A lot of them don't want to go back on it because they're afraid of having it again. But there are certain patients who are willing to try it again while on prophylaxis. And again, it's having that risk discussion and understanding why they want to go back on it. But it's a complicated discussion for sure. And then, I mean, to inject even more uncertainty, there's the idea of local estrogen control with things like the IUDs. A different risk, maybe not, and that complicates it further. And sometimes that's a direction where things go.
Yeah, that's a really good point. I think all of us end up having those discussions as well. Which agent confers the least risk of thrombosis, and trying to balance patient needs and whether they're using it for contraception or other reasons. So again, sort of a very nuanced discussion with your patient and trying to develop best strategy for the individuals. Thank you for that. There are a few questions related to anticoagulation in patients with COVID-19, and I'll attempt to answer some of those. And if other panelists in our group have a different practice, then please feel free to share that as well. So one of the questions is related to whether or not anticoagulation is recommended for patients admitted to hospital with COVID-19. If they're admitted for non-respiratory related disease, whether they should receive therapeutic anticoagulation. And the answer to that would be no. So the guidance for anticoagulation at therapeutic doses is really meant for patients who are on oxygen, and specifically patients that are on low flow oxygen. So for patients that are on nasal prongs, then those are patients that would be a candidate for therapeutic anticoagulation as long as there is no significant increased bleeding risk. But for patients that are on high flow nasal cannula or in the intensive care unit, and even if the high flow nasal cannula is being used on the ward or in the ICU, those are patients that were considered part of the critically ill population where there was no benefit to using therapeutic anticoagulation. And so I don't continue therapeutic anticoagulation in those patients. Sometimes, of course, we have patients that progress from low flow oxygen to high flow. And again, those are patients where it's an individual risk assessment. Sometimes patients are continued on therapeutic therapeutic anticoagulants, and other times it's reduced. And I think as a clinician, we need to be cognizant of what those different bleeding risks are as people become more critically ill. And so sometimes I will continue them, and other times I will reduce their dose down to prophylactic anticoagulants as they require more and more oxygen and progress to either high flow nasal cannula or ventilation. And then another question for the COVID population was related to duration of anticoagulation post-discharge if you decide to give your patient thromboprophylaxis after being hospitalized with COVID infection. And again, I think this is something where we all probably have a little bit of a different approach. The Michelle trial is really the only one that we have published information from, and they used 35 days of thromboprophylaxis post-discharge. Typically for patients, when I do post-discharge prophylaxis and it's based on either prior history of a provoked event, I will sometimes do 2 weeks or a month, and I will often base it on what their previous event was. So if their previous event was related to an orthopedic procedure and it happened 20 days after their surgery, then I would extend their anticoagulation prophylaxis usually for a month. And so that's my personal approach to that, but I don't think there's any hard and fast rule about that. And we might all have a different sort of strategy. But I think some of us will use that previous time frame for when their event was diagnosed after a provoking event to help guide that. Alfonso or Gregoire, if you guys have a different sort of strategy for that. No. Gregoire, same thing. Fair enough. Good. And then, Alfonso, this is a question that I'll direct towards you, and it's related to lupus anticoagulant from the thrombophilia perspective. And in the guidance, recommendations made for antiphospholipid antibody testing and how that might change anticoagulation recommendations.
Right. So the panel considered all testing for all defect. So with the exclusion of family studies, where the panel considers separately a screening approach or a selective testing, for all other conditions, before getting into the evidence, the panel consider what is that is commonly tested for. And so the approach was to test for lupus anticoagulant, and there was no specific suggestion about how to test for it. So antibodies versus functional test and which combination. Again, this was beyond the scope. We refer to the standard diagnostic criteria Sapporo recently, well, not so recently anymore, revised, and to be tested as at the same time as congenital defect. So I'm not sure if this answers the question. Of course, not any defect you'll find will have the same risk association. Antithrombin protein C, protein S, and lupus anticoagulant seems to be stronger predictor of recurrence compared to other defect. But to make the work manageable, the modeling was done on a pool of patients where the prevalence of defect was considered similar. Now, lupus anticoagulant is a bit of a stretch, as we know, is more likely to be in some patients with some comorbidities compared to other, some haplotypes, HLA haplotypes of some genetic background. But that was beyond the scope of the panel. That's why the calculator will be made available, because if you know that that specific defect is more common, then testing in that setting may be more or less strongly or weakly recommended.
Okay, thank you for that. So I want to thank our panelists this evening, all of our participants. We are coming to the end of our time, and I'd like to thank everybody for their participation. In the chat, you will see that there is an evaluation that we would like the participants to please complete. And it really does give us some feedback about how we can improve for our next webinar, and if there's any specific suggestions and recommendations that you have. And also want to let our participants know that tonight's presentation has been recorded and it will be available on our YouTube channel that you can access as well through our Thrombosis Canada website. So many thanks again to all of our panelists and our participants. So thank you, everybody, and have a good evening.
Bye. Thank you.
Thank you, everybody.